Good morning, good afternoon, good evening, and good night, friends and colleagues from across the world. Thank you for joining our first Podinar session today with Dr. Carlo, Luis, and Santos. It's an honor to have you, Doctor. Welcome.
Yeah, yeah. Welcome. Well, good evening here, good morning there, and good day to everyone who's listening right now. Thank you for having me, Dr. Shah. Thank you.
It's quite an honor. You're a superstar
Oh,
from the East to us, and
uh,
we're very interested in actually learning today about your perioplastic surgery concepts and
mm,
repositioning the lip and a smile line. Very interesting topic. But before, I'd like to familiarize the audience with you, so we can get an idea of where you come from and where you're,
okay.
why you are doing things that you're doing. Well, first of all, from what I
Mm,
know of you, you're very active. You're building a school in the Philippines where you teach oral
mm,
surgery to general practitioners, which is essentially one of
yes,
the missions of the American Academy of Oral Surgery. And today we wanted to make the
yes.
announcement that you will become an ambassador of the
Oh,
Academy.
wow.
Congratulations to receiving that
It's an
recognition
honor.
from.
Thank you so much for considering me, and rest assured, I will do my very best to serve the American Academy of Oral Surgery. Thank you so much, Dr. Shah, for that.
Yeah, we're very
It's an
honored to
honor.
have you. I mean, your credentials are second to none.
Thank
But let's
you.
go through them a little bit so
Mhm.
people get an idea of what you have been doing. Dr. Santos is a
Okay.
Filipino dentist whose goal is to empower general practitioners through CIDS, Center for Innovative Dental Studies, an
Yeah.
oral surgery workshop study group founded by him, wherein he shares all of his know how to colleagues and helps treat indigent patients at the same time. Very honorable.
Mhm.
Um,
Yeah.
So Dr. Carlo was a former professor in the undergrad and taught oral surgery and oral pathology, after which he shifted in guiding general dentists and aspiring colleagues who wanted to perform specific oral surgery procedures in their practices. As you know, I think Dr. Santos is very important because only 10% of GPs really do implants and more involved
Exactly.
oral surgery
Mhm.
procedures. There's over 2.5
Mhm.
billion patients that need our care. So what you're doing
Exactly.
is a
Exactly.
phenomenal thing. It's essentially the mission of the AOS, A-OS.
Yeah, I know. Yeah. Okay. And also, general practitioners, they know how to do it. They just don't know how to do it in real time. They know by theory, but by in doing it in with their hands, they just need the push. So that's what SIDS does, Center for
The
Innovative
push,
Dental
yeah.
Studies. We're kind of like a cheerleader or a coach. So we coach them. So give them to give the confidence in doing like odontectomies, apicoectomies, so the usual oral
Epicors.
surgery stuff.
Epicors are fun. Well, you're a
Yeah.
frequent lecturer in both international
Yep.
and domestic in Asia and US via platforms of all sorts. And you focus on oral surgery procedures in your clinical and also perioplastic procedures. A lot of procedures that the periodontists and the oral surgeons have commonalities on. Um, and you have been doing this for a very long time. Your
Yes.
CV is very long with
Mhm.
continuing education, leadership roles, experience. It would take me all day to go through
Okay.
your CV, and we're very glad to
Thank
have
you
you.
so much. Yeah.
But what what is the goal with your institute? Are you going to have more international travelers come from other countries to go in, or is it just for domestic purposes?
Oh no, no. Well, it would be good. I mean, it's for everyone. With the knowledge that we share, it's for everyone. And we in SIDS, in the Center for Innovative Dental Studies, we don't. I don't, like, for example, the clinical instructors and myself. We don't consider ourselves like above everyone. We're all a level. They know something that we don't. We know something that they don't. So it's like a picnic where we get to share ideas, and I would love to have international participants, but definitely they know something that we don't, and it's a good avenue to share, to like what I said, it's like a picnic, sharing ideas, showing, and yeah, and giving back at the same time.
Sure, we're
Yeah,
all equals. There's no doubt about it, and you're dang right. The new generation knows a lot that we don't know, and we're learning
yeah,
from them as much as they learn from us.
definitely, yeah. Hmm.
So, what's your motivation? Helping a lot of dentists. That's wonderful. What is the end
Hmm.
goal? What is your legacy going to be, Dr. Santos?
Well, actually, here in our country, in the Philippines, I just want to well, there's like a faction in oral surgery, um, like for example, in our part, we if the procedure is out of our wheelhouse, definitely we will refer like the for two above. That's for maxillofacial surgery. We give it to maxillofacial
Yeah,
surgeons, but as much as possible, of course, one of the goals also is to, giving back. Only way we can give back with our profession, is like, treating patients, indigent, and yeah, the poor, the people who can't afford. So mostly the patients that we get are the patients who consulted other surgeons and couldn't afford the bill. But yeah, so we give it for free actually. And
I'm
like what I
glad
said,
you're keeping it honest.
yeah.
There is times when we have to refer. There's no doubt about it, and we should
Oh
do that
yeah,
frequently.
definitely. Oh no, that's the welfare of the patient is the number one. That's the most important. The welfare. You can't like do something that you're not familiar and you're not uh, equipped to do it. So definitely we refer.
Very
So
smart.
yeah.
We have a problem in the United States is
Hmm.
the weekends. Although
Okay.
I love my oral surgery friends and I have a lot of them, they're having a good time on the weekends with the family and they're
Okay. Okay.
gone. And
Yeah.
in the
Yeah.
hospital,
Uh-huh.
ED rooms are empty. So what happens is
Oh,
patients that have any kind of
dental problem.
emergencies, they go to the
Yeah.
emergency room, but the oral
Oh,
surgeons aren't there. They have
I know.
started
I know.
migrating out of the ED into
Mhm.
private practice and are doing a lot more implants and extractions and things
Yes.
of
Yes.
that
Yes.
sort,
I know.
but
I
has
know.
created a
Mhm.
multi-billion-dollar problem on our
Uh-huh.
economy where
Uh-huh.
the oral surgeons are simply not there. They're not there on the weekends. So the patients
Yeah.
always get antibiotics and pain medication. They get sent home. And
Always.
then Monday
Always.
morning, what's
Always.
that? You have the same problem?
Always. They do that always. Yeah, of course, in the emergency room, they always the end result is giving so much antibiotics like
It's very
uh
bad for the patients.
coamoxiclav.
It's very
Those.
bad for
I know.
taxpayers and the economy. And the oral surgeons could
Exactly.
fix that,
Exactly.
but they don't.
Exactly.
So what we have is a situation where the patients on Monday goes to a dentist,
Mm-hmm.
and then the dentist has to
Mm-hmm.
reevaluate and see if that's something he or she can do, and then has to
Uh-huh.
refer them again to oral surgeons. So they went from the hospital to the general practitioner, and they
Yeah.
may
Yeah.
end up now with the oral surgeon. It could have been all prevented if the oral surgeon was in the ED room that Saturday night.
Exactly. 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 Well, the
So
statistically the
we
most
really have to
common.
work with our oral surgeon because it not only creates a tremendous inconvenience and puts the
Yes,
patients
I
at
agree
risk,
totally.
but also it is a
Mm-hmm.
big drag on our economy off the back of taxpayers. So our oral
I
surgeons
know. I
really
know.
need to step up the plate. They need to really get back into the hospital settings and actually be
Yeah. Yeah.
present to a certain extent on the
Of
weekends.
course.
But apparently you have this problem as well, huh, in the Philippines?
Yes. Yes. Definitely. Yeah. We do. We do. Like the usual statistically the usual problems is pericoronitis, or third molar, the emergency, like excruciating pain, pericoronitis. So they tend to give so much antibiotics to the patient, IV antibiotics, and of course it's that's not the treatment. Even like pediatric patients, we see them like the end result is the emergency room, the emergency facility gives them antibiotics. So man, I know it's also a problem here. So there,
So I understand. That's very good. It's not the best care. So
yeah.
the The oral maxillofacial
Hmm.
surgeons could actually initiate some kind of treatment, likely in the hospital, if it's a scenario that needs intervention. Anyway, so
Yes, yes,
plastic. We're going to talk a little bit about aesthetic oral surgery today to create aesthetic environments for the final prosthetics. You're going to take over that. I'm very
hmm.
excited to listen to your lippy. I have often lippy
Thank you, Dr.
smile. I
Shah.
mean, gummy smiles coming in with the lip
Oh
uh,
yeah, yeah.
rotation. So, would what other issues do you see that we could improve upon between the oral surgeons and the general practitioners to make things easier, better? Because you know that if the general
Okay, well,
dentist knew how to do it right, there would be less
actually,
complications, less
mhm,
frustration.
mhm. Oh, definitely,
So how can we
definitely.
work more closely with our
Like
oral
a
surgeons?
prescription of antibiotics. Yes, yes, definitely. So what we're doing, that's why I applaud the Global Summit and the American Academy of Oral Surgery because you tend to educate. That's the most important part of it. You educate general dentists in all aspects. I mean, not only oral surgery but pharmacology, prescribing medicines like protocols. So yeah, amazing job what you're doing. Kudos to
Very smart.
the American Academy of Oral Surgery. Yeah. So there.
Yes. Educating the
Okay.
general dentist is a great concept, but how do we educate the specialists, especially the oral surgeons, about working
Well,
closer with GPs?
that's why in SIDS, in the Center for Innovative Dental Studies, we don't call general dentists as general dentist or general practitioner. We like what I said, we empower them. We call them general specialists. That's what we call them because sometimes like what I said,
I like it.
it's about loving what you do. Yeah. So if they like what they're doing, like for example surgery, they're into it. So I think co-management is one of the most important aspect in the treatment. Like what I said, the welfare of the patient is the most important. So communication with the oral surgeon and the general specialist is very important for the patient's care. What else? Not only with the oral surgeon but with the medical doctor. Co-management. I think that's very important.
Co-management, very good. Yes,
So
we must be able to also
yeah,
educate the oral surgeons because some of them are so far behind in terms of what's going
yes,
on in
yes,
the actual physical place. That a
yeah,
multidisciplinary approach would certainly help patients a lot more than
yes, yes. Actually,
saying, "Hey, we're gonna leave the emergency room on the weekends. We're gonna go into private practice. Then we want to do
uh,
all of the implants, all of the oral surgery. It doesn't work that way. Patients end up
it
in our
doesn't work
chair a
that
lot
way.
more often, and we need to learn how
Yes,
to
yes.
refer when it's indicated.
Oh
Awesome,
yeah,
Dr.
definitely.
Santos. You are such a
Yeah.
kind man. If people are actually able to learn
I,
from you to maximize the
mm,
collaboration, so there is no general dentist and oral surgeons. We're all the same. We're all doctors. Ultimately, we
we're all
want the same
doctors.
for the patient. That would be a
Yes.
wonderful thing. But with that said, I mean, I think
Mm,
we're all ready and excited to learn a little bit about your technique. Earlier in the green room, you were telling me that
yep.
it's not that technique sensitive. Most dentists can do it. So we look forward
No, no,
to
no.
this
Mhm.
presentation.
Okay. Yeah. Thank you so much. Thank you so much, Dr. Shah. So yeah, just relax and I'm gonna proceed now with the presentation. Thank you. Thank you.
Thank you so much.
Okay. 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 Wait, sorry. Why? Why?
You
Mhm.
can proceed, Doc.
Okay, there. Okay, is it in the screen? Okay, okay. So I'll start now. Okay, so
Yes.
yeah, person. Okay, so good morning. I'd like to talk to you today about lip repositioning or management of gummy smile patients. First, I'd like to thank the American Academy of Oral Surgery Global Summit for giving me the opportunity to be part of this very prestigious continuing education program that they're doing here. I mean, it really really makes me happy to know that that not only here in my country, that also internationally sharing our love for our profession is actually being done. So here, right here by the Global Summit and the American Academy of Oral Surgery, to Dr. Shah, thank you for considering me to be your speaker today. So without further ado, so here we go. No, so okay, so we're going to talk about perioplastic surgery. Okay, I'm going to focus more on the gummy smile. You know, sorry. Hello. Okay. All right. So okay. So oral plastic surgery for the general dentist. Okay. It's going to be a case-based discussion. Okay. So like what I said, gummy smile management that lasts. Definitely sure you know you've heard or at least read about lip repositioning and what it does. I'm gonna tell you now, doing this procedure, relapse is gonna be your one of the problems in this procedure. But worry not, but because we found a way, there's a way for it not to relapse. Okay, so to start, okay, what is perioplastic surgery? Well, we'll know about that in a bit. Procedures done in perioplastic surgery. So, these are the. I really encourage the general dentist to do the procedures that I'm going to present tonight, no, today. So these all of these procedures are not technique sensitive. You can if you have a scalpel, if you know how to do interrupted sutures, you're good to go. Okay, so you can add this in the arsenal of your services in your practices. Okay, one is melanin depigmentation. Okay, of course, in aesthetic. So perioplastic surgery is basically the surgery before aesthetic dentistry or cosmetic dentistry. So this is the surgery done before you proceed to your veneers for your crowns. So melanin depigmentation, this is for the dark gingiva. Of course, this is more technique sensitive, but I'll just talk about it a little. Connective tissue grafting, okay, lip repositioning, aesthetic crown lengthening, and of course, part of the perioplastic surgery that we've added is guided bone regeneration and guided tissue regeneration. Okay. So once again, I'd like to introduce myself. I'm Dr. Carlo Santos. I'm a practicing dentist here in the Philippines. Well, I don't want to call myself an oral surgeon. Because I still do normal general dentist work. You know. Okay, so but I'm very very much interested in surgery. So I'm the program director of SIDS and there. So I won't talk about myself. Let's talk about the general dentist. So okay, a little about my our study group, so to speak. We have this group. It's called Center for Innovative Dental Studies. What we do is like 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 what the Global Summit, like what American Academy of Oral Surgery does. We empower general dentists. We teach general dentists the basics. The oral surgery. Um, like what Dr. Tian was talking about a while ago, that a big percentage of general dentists doesn't, is not confident to do difficult extractions, odontectomies, apicoectomies, even like bone surgeries. And like what I said, we are here to, boost their confidence, to empower, to coach them how to do it. So this is our workshops that we hold here in the Philippines. We have a facility here, so we cater to general dentists, well, specialists, and sometimes students come over to observe, and we welcome them. Not only is the participants, not only do they learn, but also the patients we get, from hospitals, from, well, from these are patients who, poor patients, indigent patients. We get to treat them for free, and yeah, and in the process we learn. Okay, so we give also free webinars for general dentists, most especially in the time of the pandemic. So at least we get to engage our colleagues, and give them tips on how the protocols, the different procedures, etc. Okay, so the Center for Innovative Dental Studies, to both participants and patients, very, very similar to what the Global Summit and the American Academy of Oral Surgery does. Of course, we give, not only to the patients, but to the participants. We share, okay? We share our knowledge, our techniques, and of course, we learn, okay? So not only does the participant learn, but also us, and vice versa. The participants get to become more confident, learn how to lecture, not only to manage cases, but to share their knowledge in return. Okay, so this is us. Okay. This was before the pandemic, when disposable OR gowns were enough. Okay. Okay. Okay, this is one of the patients that we do for free. Every month we have a this project, that Bring Your Smile Back project, that we give oral pathology patients free treatment. No? So here we have a patient who has a dentigerous cyst. Okay, so the usual procedures, of course. This is actually, well, a kind of, I mean, technique sensitive. So participants just observe and assist. So if they need further training, of course, this is kind of advanced for them. But yeah, we give them the introduction, and get them to participate in handling cases like this. So here we enucleated the dentigerous cyst, and okay, there we go. Okay, I'd like to also acknowledge and give a shout out to a good friend of mine, Dr. Aaron Gard. He's the pioneer of the autologous blood, okay, concentrates. I thought to I decided to include this in the treatment. Just because it's full of potential. We all know that this procedure is full of potential. The autologous blood concentrates, right? So growth factor and all. So we just placed a couple of these RH recombinant human growth factor here in the enucleated site. Actually, I just thought we just thought about it, and it might improve the healing, and give us a better prognosis. So we sutured it. So this is the patient before, after. Patient's happy. Post-op pain was, well, according to the patient, was decreased on the third, fourth, fifth day. Okay, so happy patient. So again, this is us, and we're having a suture clinic. We're teaching them different types of suture techniques. So I'll go with this fast. Okay, so there. So we are on our 30-second batch. Okay. Okay. So that this is our facility, our participants. So the good thing about Center for Innovative Dental Studies is, after the workshop or the course, you get to have a support system. I think that's very important, support system, because like when you have cases, and you feel like two heads are better than one, and three, four, five heads, it's better than doing the procedure by yourself. Though, so that's the good thing about this. You have a forever support system that will help you, that will assist you, that will guide you. Not only us, but also your fellow participants will be there for you when you have difficult cases. Okay. Okay. So last to finish the so that you'll know what we do in SIDS. So here we have a same dentigerous cyst. So we did a marsupialization procedure here, and remember all of this we do for free. We don't charge a single cent. Even the biopsy, we send it to the histopathology, and we all give this for free. Even the medications. So this is our actually our this is our promise to, this is the chance of giving back. Okay, so there. This is one of the procedures that was done, the prepositioning. Okay, so bone graft, they learn how to do bone graft, simple bone grafting. Okay, some perio procedures, marsupialization procedures. Okay, all right. Anyway, I want to end the SIDS the presentation about the Center for Innovative Dental Studies by this quote. We rise by lifting others. Okay, so now we start. Okay, so oral plastic surgery for the general dentist. Okay, so the goal of any treatment, is to enhance the beauty and in the safest possible way. No? So often this is multidisciplinary. So we are part of the aesthetic of that multidisciplinary approach to achieve a beautiful face. Okay? Um, that's why a while ago me and Dr. Canner was talking about co-management. I think that's very important for both um, general practitioner. Well, here in SIDS we coin it not we don't call it general practitioner. We call ourselves general specialists because what we do involves well a lot, right? Root canal, prosto, and the endodontic work, a lot. So general specialists. Okay, so cosmetic therapy as a dental demand, So if you look at the picture, the left picture and the right picture, you'll see the beautiful face of this woman, this lady, and you'll see what the dental part does. It really it's a game changer having beautiful teeth. So having have said that, we really play an important role in the race to for aesthetics for beauty. That's why perioplastic surgery. Okay, well, uh, this is a surgical procedure performed to correct or eliminate anatomic, developmental, traumatic, or disease-induced defects of the gingiva and the alveolar mucosa or bone. Okay, I'd like you to focus on the screen. Pay attention to these structures because these are the structures that we will be engaging on the procedure that I will share to you. Okay, so what structures are this? These are the attached gingiva or your keratinized thick layer gingiva. The mucogingival junction. This is the line. Okay, that this is where the sorry, this is where the unattached gingiva and the attached gingiva meet, and your unattached or free gingiva. Okay, here. So P.D. Miller coined the term perioplastic surgery. Okay. Um, in perioplastic surgery, well, gingival defects like frenum, for the frenum, the color, they dealt with that. Abnormal gingival margin, abnormal gingival display. Well, it's you might be confused with perioplastic and oral plastic. Actually, oral plastic was coined because okay, so perioplastic, soft tissue augmentation, CT graft, connective tissue grafting, crown lengthening, well, Botox, orthodontics, lip stabilization techniques are part of it. So oral plastic surgery, when hard tissue augmentation and emergence profile considerations were added, it became oral plastic surgery. Okay. Okay. So these are the problems that we are that concerns perioplastic surgery. Again, I'd like to encourage everyone, to add this. These are very, very easy procedures, not technique sensitive at all. To do this in your practice, you add this. Before placing veneers, the pink and white, it's always together. So take out that black, the melanin hyperpigmentation, or that amalgam tattoo. Okay. So one is your perioplastic problems. One is the color. Okay. Number two is your abnormal gingival margin. Okay. Sorry. Normal gingival margin. Wait, sorry. Okay. Next is your okay. Next is your abnormal gingival display. Normal gingival margin. Wait, sorry. No. Okay. Next problem that you encounter is your bony exostosis. Sometimes patients find this very, very unesthetically pleasing, the bony exostosis. And for those of you who does implants, this is part of the perioplastic issues that we deal. Emergence profile. Okay. Okay. Before we do the perioplastic procedures, we have to identify what are the types of smile. Okay, that all of us have. So one is your commisure smile or your Mona Lisa smile. This is the type of smile that when you introduce someone, acquaintance, hi, this is Dr. Kianer. I'd like you to meet my friend, okay, Dr. Santos. So, hello. So, just the Mona Lisa smile. Next is your social smile, okay, or Cupid smile. This is the smile that all of us do in Facebook and Instagram. So this is the practiced smile. This is your aesthetic smile, your beautiful smile. And next is your spontaneous smile or complex smile. Okay, this is the when you're really happy and you smile or laugh uncontrollably. It's like having your occlusion on maximum. This is your smile in maximum. Okay, complex smile or spontaneous smile. So now, okay, having have said that, so I'll go with this really fast because I want to focus on the lip repositioning procedure. Okay. So we know this in our undergrads, the normal gingiva, coral pink, stippling, and all. So I'll just go fast with this. And of course, we have to have an index, for us to chart it. Okay. So we're talking about the pigmentation. So gingival depigmentation. Okay, this is one of the perioplastic procedures that I really encourage everyone to do. Okay, this is not technique sensitive at all. I'm very sure, I'm confident that anyone, even practitioners who don't like blood, can do this. Okay, so to summarize, so it's a perioplastic surgical procedure whereby the gingival hyperpigmentation is removed or reduced by various techniques. Okay, so this is actually the best. Personally, me, I use this technique, the scalpel, used for partial thickness. Okay, again, for the general practitioners, okay, there are two types of flaps, partial and full thickness. So when you say partial, you leave periosteum or you leave tissue. Okay. When you say full thickness, you elevate the periosteum and only expose bone. So here you do a partial thickness, flap, or you take out that layer. Okay, using a number 15 blade, scalpel blade. Okay, so it just involves surgical removal of the gingival epithelial layer along with a layer of underlying connective tissue. Okay, so what you do, you just it's like peeling a kiwi, a kiwi, or an apple, if you, or a potato, it's a controlled way. You have to, it's not scraping. You don't need to scrape it. You just need to slice, go through it. So the problem with the blades, when it engages the tissue, it becomes easily dull. So you'll be needing a couple of it. And it's pretty cheap, compared to lasers. And like how much is a laser unit compared to a blade? I mean, I go with the blade. So then, okay, you allow the newly connected tissue to heal by secondary intention. Okay, so it's just that, no. So just ready a gauze. Well, what we do, we soak it, or not soak, we dab it in lidocaine with epinephrine, and on that area we dab it. We apply pressure. Okay, until we see the brown or the pigmented areas go away. That's the time we're going to stop. So even if it reaches the bone, remember, you're just slicing it out. You're not elevating the periosteum. Okay, you might be asking, shall we put a periodontal dressing? Personally, I don't, because it's more important for the patient to be able to clean the area rather than food debris be trapped there. Okay? So this is it. Sorry, it was amateurly taken, the picture, so it's not that clear. But yeah, the whole idea is it's just filleting the layer, okay, with your blade. So this is one of the patients that our participants, the students, did. So see, from the very dark gingiva, it became pink. So ready for your veneers. Okay. Again, this is one of the procedures that we can also absorb in our practice by using abrasion with diamond burr. Okay, so using your diamond burr, it's like a sweeping motion. Okay, but I like the blade more better because you need more control here. It might, you might too much force can make you perforate the periosteum, and that's gonna be bad. So, but you see, the end result is the same. So this is like basketball. The main goal is to shoot the ball, but there are different ways how to do it. Okay, so it's like this. Sorry, is it playing? Sorry. Okay, so well, sorry if it's not playing, but anyway, yeah. Sorry, sorry, sorry. Wait, let me go back. So there, it's just a sweeping motion. See, while irrigating, of course, and you just do your local anesthesia on the vestibule and on the area. That's it. The secret with doing your anesthesia techniques is the slower the better. For the epinephrine to activate. Okay. So for there you see the pigmentations. So here we use the diamond bird technique, and there, so no more. Okay. So laser ablation, this is the more expensive one, but if you have this is actually, you can use it for that. But yeah, but like what I said, I encourage the more practical means for our general dentist or general specialist. Okay, so okay, most of the questions, will it reoccur? Will the pigmentations go back? Well, if you don't address entirely the pigments, it will definitely go back. You have to address it. So there. Okay. Another problem in the perioplastic world is your abnormal gingival margin. Okay. Again, I really want to stress this out. Sorry, your biologic width is very important. Some of us, we do our veneers, direct veneers. We exceed, the biologic width. That's actually bad that's bad. I'm telling you. So you have to be aware of this. So before doing procedures like this, you have to be familiarized with the biologic width. A good foundation in periodontics is Uh, Very important. Okay, gingival hypertrophy, etiology. Okay, so we can do gingival recontouring here, gingivectomy, whatever you want to call it, or do you use your cautery, electrocautery machines. But of course, we have to, we have to treat it by knowing what caused it. Okay, if you do it and then it's just gonna come back, I mean it's useless. So usually this is caused by medications. So again, co-management with the medical doctor is very important. You can talk with medical doctor about alternatives. That's very important, and then you can proceed to the procedure that you're gonna do. So I'll go fast with this. Sorry, this is not the main procedure that I wanted to discuss. Okay, so here the subepithelial connective tissue graft. So our participants also we have them try this, but this is a little more technique sensitive. But I mean, remember, there is no oral surgeon or anyone in our profession who is gifted with good hands. The secret to everything is repetition. It's the mother of all skill. Repeating and repeating and doing it makes you good, makes you better. There's no like a prodigy in our profession in procedure. So yeah, don't well avoid. I mean, failures is good because it's the mother of success. But of course, we can't fail in our patients. That's why in our facility, in our workshops, this is the time where I don't want to say practice, but hone our skills in doing such procedures. Okay, so this was done by our participants. So this is they chose to do this canine. So okay, sorry for the amateurly taken picture. So this is the first day, second week, third week. Not bad. They haven't followed it up yet, but let me go back to. I'll definitely update you with what happened. But definitely, it's a very big difference. And for a first timer to do a connective tissue graft procedure, amazing actually. So there, it's sort of keratinized. This is one of the procedures I've done when I was starting. So anyway, a lot of techniques have evolved. Let me go through this fast. Sorry. Here we go. So this is your excessive gingival display or your gummy smile. A lot of the percentage of our patients with this, are actually high. And the funny thing is here is patients who has this excessive gingival display actually considers, I don't know why, but always, well, maybe it's a layman's uh, perception or how they perceive the treatment is. They tend to think that the treatment for this is orthodontic treatment. But well, it's part of it. You can, but there are a lot of alternatives. There are a lot of treatments, modalities that actually I recommend. Again, I strongly recommend you, the general specialist. I recommend you to add this in your practices. So let me show you. Well, not all gummy smiles are the same. Okay, so this is my daughter. So she has a gummy smile. Maybe someday I can fix it. But right now she's so adorable. So uh, I just wanted to show you guys her cute gummy smile. So this is how they do it. I'm no orthodontist, but yeah, they use studs. And if you see this, the patient has an altered passive eruption or the gums overdeveloped over the tooth or the enamel. Okay. Okay. So the different types of gummy smiles. Okay. So number one, patients with facial proportion issues. Two, patients with short lip. I'll explain about this in a bit. Okay. Number three, hypermobile lip. What is this? Okay. Number four, tooth proportion. Okay, so I want to share the story of these three patients that we had. Okay, one of them is a dentist. This Dr. Veloria. This lady over here. So actually, her self-esteem is, quite low because of her smile. That's what she was telling us. She really has a bad, a gummy smile. Okay, and the next patients, the two of them actually also went to our workshop complaining of the same problem. So they all have a controlled smile when they smile. They practice their smile, and of course sometimes being too happy at times it tends to expose the excessive gingival display that they have. Good. So join me and let's see what happened to their journey in achieving that, a lasting treatment for their gummy smile problem. Okay. Okay, so let's talk about facial proportion. Okay. Vertical maxillary excess. Okay, what is this? So this is the overdevelopment of our maxillary upper jaw. Okay, it's overdeveloped. So treatment options, actually, we have a lot. Orthodontic surgery. Okay, well, lip repositioning, so, aesthetic crown lengthening, and combination of the procedures mentioned. Okay, so orthodontic surgery. This is too morbid. Okay, and post-operative discomfort is definitely will be definitely there and definitely be present. So if the patient doesn't want to undergo this, we rule it out. So what's left is your lip repositioning and your aesthetic crown lengthening. So this is your vertical maxillary excess. Okay, it's very important to diagnose the patient. That's one of the, according to Zib Simon, well, a friend of mine, and I've learned a lot, also a lot from him. Uh, according to him, diagnosing is one of the key to a good prognosis. Okay, so you'll know what approach you're gonna do. Okay, again, this is vertical maxillary excess. Okay. Okay, short lips. So what is a what's the characteristics of a patient with short lip? Again, decreased height of the upper lip, usually arched. So these are the patients. So this one also, she has a short lip. Look at the, okay, it's arched. This is not the smile, the smile line that we want. Okay, so 4 millimeters gingival display when smiling and common in female. All right. So one treatment modality is Botox. Dr. Aaron, they've been they've been doing this combining Botox, also autologous blood concentrates, and amazing the work they've done. They actually combined the technology with our dental profession. So kudos to you, Dr. Aaron. Okay, and of course combination of both. Okay, so short lips. You see the arched lip. Okay, hypermobile lip. Okay, so this is the lip movement upon, okay, lip movement upon smiling is 6 to 8 millimeters. So that's the normal. So hypermobile lip moves 2 times the normal. Okay, so when you smile, the movement is 6 to 8. When you smile, it goes up. Your smile goes up 6 to 8 millimeters from where it is. So smile, it goes up 6 to 8 millimeters. So that's the normal. So if the abnormal is 2 times of it, so it's around 12 millimeters. Okay, so that's your hypermobile lip. So the lips and the muscles, the elevator smile muscles are the one concerned with this. Okay, so treatment, lip repositioning, and aesthetic crown lengthening, or combination. Okay, so hypermobile lip. Okay, lastly is your tooth proportion or your tooth proportion problems, your altered passive eruption. So excessive overlapping of gum over the enamel. Okay, if you X-ray that, if you have an X-ray, a OPG of this patient, you'll see that the tooth is quite normal, but the gingiva grew over it. Okay, okay, resulting with a short clinical crown. Okay, so aesthetic crown lengthening. Well, it's good to use this gauge, the chew proportion gauge. It's a nice tool to have. You don't need, you just place it on top, and there are markers that you follow. So Yeah, but it's also good to learn the not using this. Okay, again, lip repositioning or combination of both. Okay, so okay, let me define the lip repositioning. So lip repositioning is a surgical way to correct gummy smile by limiting, okay, take note, limiting the retraction of the elevator smile muscles. Your zygomaticus minor, levator anguli oris, orbicularis oris, and levator labii superioris, and yet preserve the labial freedom. Okay. Okay, so these are the muscles involved in your sorry, in your lip repositioning. You have your orbicularis oris, your zygomaticus major, minor. So, well, that's the only thing that we will be touching. Okay, so pay attention closely to these muscles. Okay, okay. So again, so this is her, Viloria. So when she smiles, it's like this. So this is her with her controlled smile. This is her with her complex smile. Okay, so again, our other patient with excessive maxillary, okay, so the overdevelopment of the maxilla and your altered passive eruption. So these are the facts. Okay, so according to Allen EP, no, use of the okay from 1988. Okay, a lot of articles online about 104 publications, but no conclusive literature has been published in the treatment of excessive gingival display. Most are just techniques done, and and its description. Okay, all are short-term studies. There's no really full-scale study about this procedure, and of course, long-term stability is questionable. Okay, so randomized clinical trial, Lumiere et al. 2016, they tried to modify the technique by doing myotomy. So they cut the muscles. They cut the muscles. They eliminate the muscles of the elevator smile muscles. Okay, so they found out that by doing this, it really lengthens the the long-term stability, if they manipulate the muscles. But cutting it, actually, it doesn't limit it, but it stops it. It really, it takes out its function. Okay, so again, these are the facts. Hyperactivity of smile elevator muscles can be treated with several techniques. Okay, so this is the cause of the problem. So we have to address this. The smile elevator muscles. Okay, okay. For predictable results, limiting muscle activity will yield less upper lip movement. Okay, thus muscle containment is imperative. So this is a by Gustavo Javier. Okay, they did this 2017. Okay, again, correct armamentarium. You'll be needing it again. I have to stress this that you should invest on good quality instruments. Good quality instruments gives you good quality results. Okay, so we measure the. Okay, so this is again. Please pay attention. I'm gonna go over the how it's done. Okay, as much as I want to show this to you live, or I can't. So I hope this presentation will do. So first, you have to measure, identify what's the etiology. What's the you have to diagnose first what type of excessive gingival display your patient has. Okay, and then you measure the amount of gingival display seen. So this is around 17 millimeters, okay? From the tip of the papilla of the middle papilla to the tip of the ging here the shown gingiva. Again, the areas that I was telling you a while ago, very important. Your attached gingiva, your unattached gingiva, and the junction where the two meets. Okay, very important. Okay, so again, this procedure, we've done this. A lot of general specialists or general dentists in our workshop, they've done this and yielded really good results. So this is how it's done. So the first incision you make, of course, given that you've infiltrated or you placed your local anesthesia, your lidocaine or silocaine in the vestibule area, okay? Muscle vestibule area. Remember, do it in slow motion. So the area that you're going to work on is the mesial. Remember, the mesial of the first molar until the mesial of the first molar on the other side. Okay? So there are two ways to do this. One is, including the frenum, but personally, I don't want to include the frenum because this is an important landmark. This is a landmark to know where the midline is. If the patient has a broken nose, crooked nose, at least you will have a guide where the midline is. Okay, so you cut an incision, a steady incision. Okay, following the mucogingival margin. This is the area where the attached gingiva and unattached gingiva meets. So make an incision until the mesial of the first molar, and then you do it again. So by stretching your upper lip, okay, from here, from where you did your first incision, you measure 12 millimeters. This is uniform, okay? So 12 to 14, don't exceed 14. Excuse me. Okay, so 12 millimeters. For a while, okay. So, for a while, okay. So you measure 12 millimeters, okay? 12 to 14, and then here you make another incision, maybe around 5 millimeters deep. Okay, so yeah, around 1/4 of your or of your number 15 blade until the mesial of the first molar again. Okay, sorry, and then do it on the other side. Sorry, do it on the other side. So this is an illustration of an incision including the frenum. But like what I said, I personally uh, suggest that you preserve the frenum. But it's up to you. If the patient needs a frenectomy, to consider doing this. So it's like this. You do a split thickness flap. Okay. When I say split thickness, you get the end of the tissue and then use your blade to cut. It's like separating the skin of the pig. You just cut that area. So don't involve the muscles first. Okay. So wait. Let me. Oh, sorry. Okay. So sorry. So here you can see the strip of unattached gingiva that we've got. Remember, the measurement is from your initial incision, it's 12 to 14. Okay, so it's like this. So look, so see, while stretching the lips, okay, that measurement you did, you can use your probe or your what do you call this, your any sharp instrument to make a mark, or you can use your bio pen, your violet pen as a guide. But make sure your measurement is correct. Again, okay, let's proceed. So it's gonna look like this. Okay, as you can see, you can now using your gauze just wipe the epithelium away. This one, and you will be able to see the strands of the muscle strands. Okay, it's going to be different directions. So that's your muscle. So again, anatomy is very important. So here you're going to have your orbicularis oris, zygomaticus major and minor. All right. So okay. Again, we've in the past we've done this, and we just after that procedure we pull it down and then suture it. Okay. But remember, we're dealing with epithelium. It's like doing a pedicle flap, for oroantral communications or any type of flap wherein you try to do a releasing incision. Okay, the vestibule will definitely return back because this is epithelium. It's elastic. So having have said that, if you do this, if you just only pull it down and do your sutures, believe me, uh, 80 to 90% it will relapse, and a perfectly full of potential procedure is wasted. So okay, so what you do actually, again, a while ago I mentioned you limit the function of the muscle. You don't eliminate the function, you limit. How do we do it? Okay, we con- uh, by containing the muscle containment, or we bundle it. Okay, as you can see here, this is the orbicularis oris. Okay, you don't need to grab or contain the whole musculature, because that's impossible. You just need to grab a little or contain a little. So it's like, for example, imagine four individuals lining up carrying a big, for example, let's say a barbell. It would be easy for them to stand beside each other, four of them, lift the barbell easily, because all the force distributed, divided by the four individuals, if they lift it, they'll be able to lift it with ease. Okay, if you tie those four together, if you bundle them together, tying them like it's like putting them in a situation where they're tied beside each other, not falling in line, not in a horizontal line, but bundled together, and ask them to lift that barbell, it's going to be difficult for them. So that's what we're doing. We're containing, or we're bundling the muscles. Okay, so let me show you. Wait, let me show you this. Okay. So I hope you can see it, but at least I'm giving you an idea on how to proceed about, in this bundling or containment of the muscles, the elevator smile muscles. So again, this procedure, you just have to, repeat and repeat and repeat for you to be able to do this, with surgical grace. It's like dancing when you're having your surgical. It's like you doing it naturally. Okay. Okay. So yeah, you bundle it there. Okay. So yeah, you have an idea on how to do it. Okay. Okay, sorry for the drawing. So it's like this. You bundle actually. Okay, again, you use an absorbable suture. Okay, in the workshop, what we use is a catgut suture. Okay, it has to be absorbable definitely, because you're going to leave it inside. So the first incision, the first suture, of course, this will be at the back of the frenum. Okay, so you grab it. Okay, and then okay, how do you know when will you do the second and the third? Okay, you will see that the muscle, the linear appearance um, uh, becomes more oblique. So definitely you will see the different muscle groups. If you wipe the epithelium, the fascia with your gauze, you'll see the different directions of the muscle fibers. So you follow that. Again, you don't need to grab everything. You just need to grab a hefty amount of muscle and bundle it. Okay. Sorry. So it looks like this. You just like what I said. This is not technique sensitive, because you just do your interrupted sutures and you're good to go. So there. Okay, I'd like to show you this case that we did. So this patient of ours, went to the facility for treatment, and because she's really insecure with her gummy smile. Okay, again, shout out to Dr. Aaron. So here we tried using, I believe once you know the basic, that's the most important thing, like learning to swim. You can't like learn butterfly stroke and not learning how to float or to tread. So we know, having have said that, knowing the basics, we again thought of placing autologous blood concentrate in the, because post-operatively, this will take a little longer to heal because we're dealing with muscles. It's like having a sprain, or a stiff neck tendon. So they tend to heal a little slower than your usual epithelium. Okay. So the usual side effects of lip repositioning actually are, well, you're going to have mucocils because those minor salivary glands will be part of the damaged area. Also scars in the vestibule, but of course that's not going to be seen, so it's okay. Again, talking about the autologous blood derivatives, so because of the post-operative, well, more post-operative discomfort, we tried using this. So finishing our bundling, um, we tried using this. Okay? Some of the comments when we did this was, Doc, will this make this thicker? Will this make it more plump? Will it add to the keratinization? Actually, to answer that, I don't know. We just thought that this was, viable because of the potential again of autologous blood derivatives. I'm not asking you. I'm not asking you to do this, but I'm just showing you that we just, well, played with it, or experimented on it, and I think, well, the it showed that, the patient reported to us with less, the healing with less post-operative discomfort. It's like doing an odontectomy procedure. After 5 6 days, the patient was okay. It's actually unlikely with lip repositioning, which usually lasts 2 weeks. The post-operative discomfort, the tightness. Okay, so there we place the autologous blood derivatives. Okay, so if you look closely, sorry, wait, I just want to show you this. So this is that's how it looks like when we bundle the muscles. Okay, sorry. Okay, so then we suture. Okay, so post-operatively, this is the patient. Post-operatively, okay. Notice the upper lips. Okay, doc, is this inflammation? Well, it part of it is inflammation, the upper lip, but the good thing that actually the ladies, our female patients love about these procedures, it's like it's a side effect actually. It makes the upper lip thick. It's like having a lip fillers, and they actually like this side effect of. So sorry, I haven't really researched on why this happens, but this is one of the side effects of lip repositioning. Okay, 1 week post-operatively, you see the difference. Okay, um, like what the American Aesthetic Dentistry said, a 2 to 3 millimeter of interdental of show of the interdental papilla is, needed for a good smile. Okay, so there we have it. So 6 months post-operatively, you see it normalized. This smile is you'll see later. Okay, this is a complex smile. Same with the smile she was doing a while ago. Okay, 1 year post-operatively. See, she still has her braces, but see her smile. You can see in the lines of her face that she's doing a complex smile. So 1 year post-operatively. Usually procedures like this, it doesn't last long. On your third, fourth month, a hefty amount of gingiva will show again, and it's really actually depressing in the surgeon's part, and frustrating for the patient because it wasted a good for procedure. The patient underwent discomfort, but relapse will happen. So, but manipulating the muscles, look, it's very beautiful. So again, this is the what it looks like, the scarring. Look at the scars, okay? But it's okay. If you're keloidal, it's better because it's part of the locking mechanism. It locks that we want that tightness to be there. Okay. Okay, this is our patient. Look, so 6 months post-operatively. Okay, this is done by Dr. Tutanes, Gemma Tutanes. So one of our participants. Amazing. So 6 months, even the lipstick changed. But kidding aside, you see a really big difference. Okay. Okay, this is the patient of Dr. Judith, one of our favorite students in the SIDS. So you see, the patient is also insecure about her smile. So, okay, altered passive eruption. Okay, so here, sorry, this is after 5 months. So look at this pre-operatively. The patient doesn't even has a unsymmetrical. The her smile is not symmetrical. Well, this can be fixed also by combination of crown lengthening and lip repositioning. So again, a closer look. Okay, 1 week post-operatively, notice that it really looks tight. Okay, 6 months post-operatively, again look at the lips. It thickened compared to this. See, the lips thickened. Okay, so this is your 6 month. Okay, 2 years after. Look at the difference. Okay, this actually can be. I think she's scheduled with her dentist, Dr. Judith, to be restoration is going to be changed and a aesthetic crown lengthening procedure will be done. And definitely look, if you do, because her gingiva, there's altered passive eruption happening here. When you do an aesthetic crown lengthening, this will look amazing compared to your pre-op. So this is 2 years. Imagine 2 years. Okay, again this picture. So look, look at the difference. This is 2.5 years without any relapse. Same type of smile. It's your complex smile. See the difference. So Dr. Veloria is scheduled for Emax veneers. After that. So this is just composite that we placed, but amazing. Look at the difference. It's quite. She was emotional with the results of this actually. Also, she said that her cheeks became thinner, but yeah. So we actually don't we don't know what caused that, but maybe she just got thinner. But the smile, look at the arched lips here. It's arched, the thin lip, okay, compared to the smile line that was produced, the smile line. So you see the upper lip, the upper teeth underlined by your lower lip, and your 2 millimeters show of papilla. Okay, this is another picture of her 2.5 years after. See the difference, no? Amazing. So again, all of you can do this. I believe all of you, all of the listeners now, you can incorporate this to your practice. If you have any questions at all, you can contact me on my Facebook, or I will leave my number, my contact details on the presentation on the page, so you can ask any questions, or if you need help, I am willing to go the extra mile to guide you guys for you to be able to add this to your arsenal of services. Okay, so conclusion. Okay, the present case reports describe a predictable procedure for excessive gingival display. Okay, association of a lip repositioning technique with the traction and containment of the lip elevator muscles using sutures demonstrated a good aesthetic outcome with reliable stability at a 1 to 2 year follow-up. Okay, that's quite long. I mean, I think if you reach that 1 year mark, it's gonna be it will reach the forever. I mean, the unrelapsing event. It's not gonna relapse again. So Uh, but I believe for more studies, no, should be done. So additional clinical trials and long-term studies that involve a larger patient sample are necessary to evaluate the effectiveness and stability of this technique as a treatment modality for gummy smile. But like what I said, unlike the usual technique that doesn't involve the muscles, it's gonna relapse. Don't do it. Okay. Um, do it with the involvement of the muscles. Okay, I forgot to add what are the contraindications for this procedure. Number one, people with retrognatic jaws. You know, those skeletal class 2 patients that when they smile, the mere fact that they're talking, it's going to stretch the elevator smile muscles. Also, people with thin biotypes, you know, their attached gingiva are they have thin biotype. So that's that's actually two of the contraindications, no? And the most important contraindications for you not to do this. But nevertheless, with that having said that, you can do this with all gummy or excessive gingival display patients. Okay, I'd like to end this by saying that mistakes are painful when they happen, but years later, a collection of mistakes is what is called experience, which leads to success. So, having said that, for me, when I find it difficult, I see it as a learning. I'm learning because I had a hard time. So, make it as a learning experience. In life, we don't lose. It's either we win or we learn. Okay, so guys, I'd love to answer all your questions. Please write them down. Type it down in the comment sections. I will get back to it. You can ask anything or contact me. I'll be posting my details under the comment section. So thank you for listening. Thank you for viewing. I want to thank everyone who watched and say hi to everyone who's watching. My family and my friends, students. Hello. So thank you again for American Academy of Oral Surgery for giving me the opportunity to share what I know, and hopefully I can like what I said. I often view the videos here in Global Summit, and I'm learning so much. So I hope you guys also you know learning is free if you just know how to basic is very important with the basics, watching webinars like this, you can actually incorporate the basics and you know learn and share what you've learned. Right? So, having said that, I'd like to tell everyone to stay safe and thank you again for listening. So, bye bye. This ends the my webinar presentation. Thank you guys. Thank you.